Can I just ask Dr. Chia what form he gave the oxymatrin to his patients in? And is there any sense in buying the oxymatrin that you can get off the internet, or does it have to be in purer form and intravenously?
Well, the one we get from China is a pharmaceutical product. It's registered with their FDA as a drug, herbal drug, and used to treat hepatitis B. The other one is called Meirleir, which is used intravenously to treat Coxsackie B cardiomyopathy, and that's only available in the hospital. The reason we imported this preparation from China is because it's pure. My son took it for 2 years, and we tested it out in Hong Kong. It's absolutely pure. There's no other contaminants in it. You can buy oxymatrin on the internet. I don't know how pure it is. If you want, you can have it analyzed, but it costs almost $500 to $700 to analyze it. So.
Can I ask Dr. Chia a question? Would you take oxymatrin yourself?
I've taken it 5 different times.
For how long?
The first time I had a non-productive cough for 6 weeks. My son actually told me, "Why did you take it? And maybe help." I said, "That's a great idea." I took it in 3 days. The cough went away. Subsequently, I developed, I believe, an enterovirus infection of the parotid gland. And after I seen a patient with viral meningitis with enlarged prostate at the parotid gland, I'd taken it about 3-4 times after that.
And what were your side effects?
None. The patients who have a lot of symptoms, this can be a difficult treatment to tolerate.
Sure.
The question, I'll probably aim this more at Dan Peterson, is what is the position with your colleagues over in the States who are in more ordinary clinical practice dealing with ME/CFS patients? Are they willing to prescribe these sort of drugs that we've been discussing today?
Short answer, please.
Yes, that's changed. If I see the person and recommend a therapy and start it, the vast majority of the referring doctors will continue the therapy.
Your talk was very riveting and everything sounded very high-powered. I'm just wondering, is anything that you're doing leading toward the discovery of or looking at the possibility of a novel virus that nobody's seen before in this disease? Is your research going in that direction?
Yes.
Thank you.
Sorry.
Professor Hooper.
There is a virus that's never been associated with this disease that we've submitted, and there is a paper under review at Science magazine.
Professor Hooper.
This is just a follow-up, really, to the immunoglobulin story. There's an antipathy in the UK to giving immunoglobulins IV, which seems to be the preferred route that you've all put up. Do you understand this, and what were you advised to our people giving immunoglobulins? Is the IV route something that's got particular dangers, or do you see it's not really a problem in your patients?
Well, there's this art to dosage that I totally agree with, because on a higher dose, there's significant side effects, and underdose probably isn't effective. So it takes some experience, but it's not all that difficult, and it really is a very effective therapy. I would submit that the reluctance is based on cost, not on medical efficacy.
I've got 2 children with severe ME. My daughter's been unable to stand or walk for 3.5 years. Throughout their illness, as well as the other sort of sensory and cognitive difficulties, which you're all familiar with, that pain has been a very big issue, and it still is. Severe, debilitating, and distressing every day. It's migratory pain and localized pain. We had a visit from an eminent pediatrician working in the field who said that, in her view, the pain was, she likened it to phantom limb pain. My understanding was that meant that there was nothing actually going on, but the brain was wired up in such a way that it couldn't stop receiving these pain signals. And that the solution to that was to re-educate the brain through massage, for example, and gradual changing. And I wondered if you agree with that, or do you think there's actually something going on still that's actually causing the pain, which is, I guess, what we feel as parents looking at the children?
Well, I doubt that it's phantom limb pain. For example, if you look at the spinal fluid and you look at cytokines in the spinal fluid and other things in these particular patients, they'll have astronomically elevated substance P, and which is felt to be a mediator of pain. So I think it's CNS origin, probably based on cytokine.
Do you think anti-TNF would help that patient? Kenny, what do you think?
There's another mechanism with the NMDA receptors, and that is mediated by different things, but hydrogen sulfide can change that. And so we give them oxygen. We give the patients that have a lot of metabolites of hydrogen sulfide in the urine. We gave them oxygen 4 hours a day, 5-6 liters, and mostly the pain goes away.
Would normal cardio screening show up enteroviruses that affect the heart, or could they come back reasonably clear?
Well, we look for diastolic dysfunction on the ultrasound, which is one of the signs that the heart is not contracting normally. So it's been a long time since they've been looking at diastolic dysfunction, but we didn't have a good definition of it. But now the cardiologists more and more look for diastolic dysfunction. In the last few years, there have been better definitions in the European Journal of Cardiology, published, I think, 2 years ago or 1 year ago, a new definition for diastolic dysfunction. So now we have a tool, and some patients have diastolic dysfunction.
It seems in America there's a whole battery of tests which can be carried out on patients, the US and Canada. Across here we have very little, so our NHS clinics will carry out very basic blood tests, for example, screening for anemia or thyroid problems. Now we have a big problem because we're not getting access to a whole bevy of results which could be of great help to, in my case, my daughter. How do we get access? We don't even know what tests to ask to be carried out for example, screening for other diseases or comorbid conditions or viruses or bacteria. There's lots out there that could inform us, but we don't get the results of those tests. And when we ask, we're met with a long silence. How do we deal with that, please?
Same answer as last time.
There's a ray of hope in the sense that my understanding is that the GPs anyway, there's going to be a lot more patient input into sort of joint decision making in this country, and maybe that will influence things from the patient point of view.
Speaking as a former hospital consultant, it was difficult to investigate some of my ME patients as fully as I would like, because facilities were limited. So if it's difficult for me, who's interested in it, GPs who don't perhaps fully understand ME as much as you do are a little bit antagonistic to the diagnosis, probably know very little about what to investigate. And when you think about it, people on the podium here are among the very few that investigate patients over fully, because they're doing it over fully to get as much information as possible. And it's a sort of epidemiological approach which is not really acceptable in the NHS. In fact, I don't think it's acceptable in any managed health service in Europe. You have to do it in a special environment, and that's a research environment, and that presents a big problem. When the epidemiologist researchers, like the ones on the platform here, have refined the tests to a minimum but most informative few, that I think will trickle through. But it would be impossible to do the things that Kenny does and Dan does on the patients in the UK. Where's Jonathan? Is he here? No. Well, he would find it difficult too. But I have a question, because reading the American Journal of Endocrinology recently, there was an agreement that the TSH levels that had been recognized for some years should be changed. and that the TSH level, instead of 0.4 to 4.4 with an average of 2 something, where they said over 4.5 will be abnormal, they've now reduced it to 3. So does that mean that endocrinologists are getting more sensitive to minor changes in thyroid function? And of course that flips over into treating a patient with T3 or T4 who's actually got thyroid function tests within the reference range, although they may be in the lower quartile. Dan, what do you think?
Well, there's a whole school of euthyroid hypothyroidism.
Exactly.
That there is a school of endocrinologists who treat quite aggressively. And usually they do an empiric course of therapy and then see if the people feel better or function better. So I think probably the change in range is valid, actually, is my personal belief.
Yeah. Kenny?
Yeah.
You treat patients with thyroid supplementation where their levels are currently within the reference range, within the lower quartile?
Only when there's clinical signs. Because in a lot of patients there's peripheral resistance to thyroid hormone. And you see that when you measure the urine levels. Normally there's more T4 than T3 in the blood. And in the urine there's more T3 than T4 because of peripheral conversion. In the patients with peripheral resistance, it doesn't change. The T4 is higher than T3, both in the blood and the urine. And these people have peripheral resistance. So you try to create there are probably some proteins sitting on the receptors, or receptors have disappeared. But that's a good reason to try to give a supplement to see if you can induce or increase the metabolism.
What sort of supplement?
We give combined low-dose T3 and T4.
We come along to these conferences periodically, and invariably there is optimism. I'd love to ask each member of the panel when they think, in terms of years, we'll get to the bottom of ME, but that's unrealistic. That's how long is a piece of string. So what I am going to ask, through you, if I may, each member of the panel, to indicate how far away we are from coming up with a marker which is generally, if not universally, accepted.
For the disease or for treatable disease?
For the disease.
Okay. Dan, you're on the firing line again.
Well, we have markers for treatable disease right now. But the crux of your question, I guess, is when will this be universally acceptable? And we have to go full cycle on that. It all has to be peer-reviewed, criticized. I mean, it's a long process. So as a practicing clinician, however, I can always have the best interest of the patient in mind. In fact, that's my obligation to do that. And I can, at least in the United States, I can do anything that makes appropriate logical sense for the best benefit of that patient.
Kenny?
And I do.
Put any period of time on it, sir? What do you say now?
I won't answer that.
Kenny?
In theory, we can treat everybody right now, but it's the things we have to do are maybe now the drugs are available in every country. There's some diagnostic hurdles to take, but in theory, we can treat most patients because we know, as Dan says, there are a number of biological variables that we see are changed and we can influence, and in each patient we can find the individual mechanism that led to it. We have enough things there, but I think it's just a question of acceptance and putting studies together. But we are not big pharma companies, and the only ones that get studies through in big journals are pharma companies. And this is the big hurdle, I think.
Dr. Chia, what do you think?
Well, I think maybe I can put things in a little bit of perspective. I mean, I think it does depend on what you believe in as the cause of this. Definitely, there are different causes or infectious causes of this illness. I believe, at least in my cohort of patient, enteroviruses is the most important. But if that turned out to be a totally different virus, as Dr. Judy has described, I'd be happy to accept that. I'll be happy to be just saying I'm wrong. But based on the clinical experience and over 10 years and carefully looking at the data and generating the data, I believe enterovirus is one big group of viruses to attack. If one used that as a starting point from this point, which is not even accepted by all people yet, it would take 10 years to develop a drug. That's what you're looking for. A diagnostic test, we already have. We have a few diagnostic tests. None of them are 100%. They never will be 100%. But to show the virus presence in the tissue compatible with the patient's symptoms, I think is at least a good proof there's a persistent infection. Then one can pursue from that point on. Yeah, we do try things. Now, all through the years, as you can see that with the data that I generated, yes, the patient failed eventually. But we learned a lot from that treatment. We know this is a treatable disease. As you use a ribavirin for Coxsackie-V3, you can see the antibody level drop. And when the patient relapse, the antibody rise, the viral RNA shows up consistently. You know that an antiviral drug of a nucleoside inhibitor will be valuable. This is where I'm thinking, so where do you accept things? And that's going to determine ultimately.
One very last comment.
I'm delighted to hear what you said about hypothyroid and the difference in the ranges and knocking on the bottom. Perhaps it would forward things a bit if we all asked our GPs whereabouts on the normal range our results are. And if they're knocking on the bottom, would it help a bit if we had a trial of something or other to get us nearer the middle?
You'd have to have a very, very soft GP to take that approach. But let me know when you've tried it.
It has been, my daughter has tried it, and I heard 3 or 4 days later, I heard her laugh as I hadn't heard her laugh for about 15 years.
That says it all. It's been a smashing day, and I'd like to ask the speakers to applaud the audience for sticking it out.